Chapter 6: Other Important Immunotherapy Targets and Therapies.
Transforming Growth Factor Beta, TGFB. TGFB is an important cytokine in regards to the immune response. Basically, it inhibits the cancer-attacking cells of the immune system and turns them into cancer-protecting regulatory cells. TGFB is also involved in the migration of cancer cells to new locations in the body. TGFB may not only be produced by the cancer, but also is produced in the tissue surrounding the cancer stroma. TGFB both suppresses the immune response and increases migration, and also stimulates other growth factors such as VEGF to increase the blood vessels for cancer and make it more aggressive. In our previous discussions, I have mentioned that you can have different degrees of immune infiltration of cancer, the so-called hot versus cold tumor. We know that tumors that do not have immune cell infiltration or cold are not as likely to respond to immunotherapy. In an article published by Ross, May 2018, Trends Cancer, they described how blocking TGFB may be a key aspect in changing a cold tumor to a hot one. But there are some aspects of TGFB that may be beneficial, so eliminating it completely may not be the best answer. There are drugs currently being tested which block more specific aspects, like the receptors, which should provide an anti-cancer response, while not reducing the benefits TGFB may provide. In an article published April 2018 in Immunity, Ganesh showed that combining immune checkpoint inhibitors with TGFB inhibition induced a complete resolution of cancer in the mouse model. There are still further studies needed, but there are some suggestions that the act of surgery, biopsies, ablation, and radiation may increase TGFB, further adding to immune suppression. In our work, we are looking at techniques to minimize this in respect to ablation. Also, considering the overall importance of TGFB in the immune response, TGFB receptor inhibitors are probably going to prove to be an invaluable weapon in cancer immunotherapy. This is an area we are actively studying as well. TGFB can be measured in the blood, which means it can be a helpful marker. In a study published by Shengxing Wang, Cryobiology, May 2016, they described how TGFB levels can be useful in monitoring pre- and post-treatment, and when increases in the level occur after cryoablation of prostate cancer, they are more likely to have recurrence. We are now making it standard in our practice to get serial TGFB levels to evaluate treatment options and potential results. While commercially available and FDA-approved TGFB inhibitors may be a few years away, there are reported to be a few natural inhibitors of TGFB. Although there still needs to be further studies in this area, I recommend to my patients berberine, curcumin, capsaicin, EGCG, selenium, and sulforaphane. There must be caution with EGCG since in rare cases, high doses can cause liver damage. I also think black cumin seed oil is a good option, and we regularly use losartan. Here is a limited list of a few natural TGFB inhibitors that appear in medical literature. Number 1. Curcumin, reported by Thacker +1, March 2016. Number 2. Capsaicin, component of chili peppers, reported by Choi et al., J. Agric Food Chem, January 2018. Number 3. Epicatechin 3 Gallet EGCG green tea, reported by Huang SF et al., Food Chem Toxical, August 2016. Number 4. Sulforaphane, broccoli seed extract, reported by Wu J et al., Oncology Representative, May 2016. Number 5. Berberine, plant extract barberry, reported by Kim et al., Berberine suppresses cell motility through downregulation of TGFB1 in triple-negative breast cancer cells, Cellular Physiology and Biochemistry, 2018. Number 6. Selenium Lenicky et al. Poster presentation SITC 2017. Selenium, the element of the moon, improves immunotherapy on Earth. Also of possible interest. Number 7. Red ginseng oil, reported by Trong in Molecules, September 2017. Number 8. Black cumin seed oil, thimaquinone, Mustafa et al. Thimaquinone as a potential adjuvant therapy for cancer treatment, evidence from preclinical studies, Frontiers in Pharmacology, June 2017. Off-label drugs that inhibit TGFB include Number 9. Losartan, reported by Arnold. Losartan slows pancreatic tumor progression and extends survival of spark null mice by abrogating aberrant TGFB activation, +1, February 14, 2012. CSF1R. As we have discussed, the immune cells in the tumor microenvironment play a key role in dictating the cancer immune response for good or bad. Most of the current approved immunotherapies focus on the T cell, which in cancer immunotherapy, though important, is very one-dimensional. There are other cells in the microenvironment that play a huge role in the suppression of the immune system in cancer, specifically tumor-associated macrophages, TAMs, and myeloid-derived suppressor cells, MDSCSs. As mentioned before, your immune system has two sides, one that attacks cancer and the other that protects it. TAMs and MDSCSs protect it. To enhance our immune response, we want to eliminate, deactivate, or change TAMs and MDSCs. It is now recognized that one area of weakness of the currently approved immunotherapy options is that they do not address TAMs or MDSs. This is where blocking coloninating stimulating factor 1 receptor, CSF1R, is going to play an essential role. By blocking the CSF1R, it can reprogram some of these cancer-protecting immune cells into cancer-attacking ones. Blocking CSF1R also increases PDL1 and CTLA4, making the immune system more responsive to these typical immune checkpoint inhibitors, further supporting the need for a combination therapy. Though I do not like to generalize the immunotherapy response potential, immunogenicity, of any particular tumor type, some studies suggest that CSF1R blockade may be more important in pancreatic and prostate cancers. I suspect in the future we will look at CSF1, CSF1R on a personalized level to identify the specific patients this therapy is likely to benefit the most. Tumor-infiltrating lymphocytes, TILS. In the tumor microenvironment, there may be present T cells that are recognizing the cancer and trying to fight it. The concept behind TILs is, if possible, harvest cells that want to attack the cancer. If you stimulate these cells and grow more outside the body, then reinfuse them to the patient, they may be powerful enough to eliminate the cancer. It is a reasonable concept that is already showing some success. This technique is gaining more attention now because of research published by Dr. Steven Rosenberg in Nature Medicine, June 2018, demonstrating complete regression in an advanced breast cancer patient using this technique. They selected out TILs that reacted against 4 different mutant proteins of the cancer, growing those and infusing them into the patient. This therapy, though promising, still has some drawbacks. One is that you have to deplete the patient's immune system with chemotherapy. The other is that this technique is extremely expensive. I do not want to downplay too much the benefits of this type of therapy, but it is still my belief that intratumoral immunotherapy has better potential, both in terms of success and practicality. Chimeric antigen receptor T cells, CAR-T. CAR-T is gaining a lot of attention mainly in blood-borne cancers. There are 2 FDA-approved CAR-T, one for diffuse large B-cell lymphoma, the other for relapsed refractory B-cell precursor acute lymphoblastic leukemia. The idea with CAR-T is that you genetically engineer the T cell to express an antibody receptor that targets a receptor on the cancerous cells. This has proven to be effective in blood cancers that has specific targets, but not so easy in the majority of cancers, which are of the solid type. In most solid cancers, it would not be enough to target just one mutation because cancer can generally outsmart one-dimensional treatments targeting one mutation by hiding the expression of that protein. In addition, CAR-T has been plagued with side effect issues such as cytokine release syndrome, CRS. However, in Chapter 11, I discuss how this may now not be as much of a problem with the use of an IL-1 blocking drug in combination with CAR-T. Certainly, as the technology improves, there is a good future with these drugs, and at the moment, they're gaining a lot of attention from the media and investors, but their transition to clinical use in patients has been more challenging. The huge price tag they come with does not help either.